Good day, everyone. So you've learned a lot about COPD, and now I'm going to talk briefly on how you educate the patient. My name is Sujit Rajan. I work at Bombay Hospital Institute of Medical Sciences in Mumbai. The typical asthma patient comes to your clinic with recurrent cough, occasional colds for the past 10 years. He gets attacks of bad congestion every 3 to 4 months, treated by a family physician with oral medication very often, need-based inhalers, never told she has asthma, and now meets a physician. This is very, very typical of asthma. She's been communicated, the physician or the chest physician who sees her, then probably communicates well about asthma, prescribed, taught how to use a steroid inhaler, and now the patient is remarkably better. Look at the typical COPD patient. This patient, in contrast to asthma, is a 60-year-old male, and why I brought out the asthma example is that this patient has been labeled asthma for years, bad asthma, and he wonders why so many asthma patients are doing well, but he isn't. He has no dramatic relief with the asthma inhalers. He has a poor quality of life, limited activity, and actually curses that inhaler, saying it doesn't work so well for me. Now, the key issues in communication in the clinic in COPD are understanding how much your patient will comprehend what you're saying, counseling him about smoking and how the disease can progress, understanding hyperinflation and how the bronchodilator works, which is the most important drug, nutrition counseling, exercise rehab, and finally, has the patient understood and is he comfortable with the plan you're giving him? So let's go one step at a time. Understanding patient comprehension, ask the patient which language is he comfortable to listen to it. Always ask this. Sometimes we are talking in a language or a jargon that the patient doesn't understand. So understand how much he will comprehend. And the second important thing is if he's a smoker, then please counsel him about smoking cessation and how the disease can progress if he doesn't quit smoking. As you can see on this slide here, whatever stage of COPD the smoking patient is in, his lung function or her lung function will continue to decline if the patient continues to smoke. And whatever time the patient quits smoking, the decline in lung function will be halted. So you won't regain the lost lung function, but at least the further decline, as you can see very elegantly on this graph from a study by Fletcher and Pito more than 50 years ago now, shows. So smoking is actually an opportunity for you as a physician. It's an opportunity to highlight a cause. Never yell at a patient, which was a mistake I often did as a resident. The patient is going to run away from you if he's yelled at. So understand his problem. It's a disease. Counsel him and ask him that whether he needs help, whether it's nicotine replacement therapy, a drug, or just counseling. And two simple questions are important. And this is what I always do in the clinic. Ask the patient, how important do you feel it is to quit? Most patients will say, rate this as 7, 8, or 9. And I'm sure you all agree, most patients feel who smoke that it is important for them to quit. And then ask them the second question, which is how easy is it for you to quit? And most patients here will rate that at either 1, 2, 3, 4, or 5. And then all you need to tell them is that look at the gap between how important you feel it is and how easy is it for you. And patients will realize that that's why they need help. And you've actually shown them why they need help. Then it's up to the patient, of course, to seek help. But you have at least triggered that thought in his or her mind. And just spend a few minutes, spending a few minutes, research has shown can achieve a quit rate of 3%. Sometimes use a family member to help, just write it down. I see many physicians don't even write it down in a smoker. And it remains on that prescription to remind the patient, tell him that an urge to smoke is very short-lived. And if he can pass that urge with nicotine chewing gum or a patch, he will do well and get rid of accessories like lighters, and poor patients can put aside the money they would have spent on cigarettes for more useful things in life. And I think all these things will help them. The third and very important aspect of education is understanding hyperinflation. Now, unlike asthma, where you use your breathing tube models to explain inflammation, here you need to understand what is happening in the lung. And most patients don't understand what their lungs look like. So you need to tell them your lungs are like 2 bags of air. The airways are like a tree turned upside down with the trunk here and the branches going into both the lungs. And the windpipe, which is in the neck of the patient, rarely closes. If the windpipe closes, we drop dead. And so the patient understands the structure of his airways a little better. You can show him this diagram on your laptop where the airways look like a tree turned upside down. And you can see with a normally inflated lung, the lung can move up and down with a good diaphragm, which is contracting. Then you need to tell him that when these airways are cut open, the branches look like this when you cut them open, and show them breathing tube models, which I hope you all keep in the clinic. And if you don't, please get them from wherever you can access them. Breathing tube models show you how the airway is inflamed and swollen and are extremely useful to counsel a patient about inhaled steroid in asthma. Equally so in COPD, by telling the patient that this obstruction, which you can see in the other two airways, is partly reversible and not fully reversible like in asthma. And then because this airway is partly reversible, that's the reason you have not complete relief of all symptoms with an inhaler, but significant relief. And the patient with COPD often doesn't understand the word COPD, so sometimes use the word bronchitis, because just like asthma is an allergic bronchitis more often than not, chronic bronchitis is synonymous with COPD. So use the word bronchitis, it will help you for your patients to accept that they have a bronchitis problem. They understand that the airway is swollen and inflamed, and you need to give it a label sometimes, and we call it COPD. In COPD, you can see here in this airway, there is narrowing of that airway, and therefore the lung now gets filled up with air. And this is what you need to tell your patient, that your lungs are much fuller of air than a normal patient's lung. So you can see when the lung is full with air, the diaphragm can hardly move. So someone is breathing at a very high lung volume. Such a patient, if he walks 10 or 15 meters with such a full lung, he's going to feel short of breath. He can't take in any more air. And if the patient understands this, he understands why he is so breathless, or the son or the daughter understands why the parent is so breathless with COPD. And then you come to the fact, why give a bronchodilator? And so it becomes so straightforward then. When you dilate that airway, you are deflating the lung. And that's what you need to tell the patient with this diagram. You slightly dilate the airway, the lung gets deflated. So what actually happens is there's no inflammation to treat like in asthma, but the balloon, which is now filled up with air, needs to deflate. And the more you dilate the airway, that means the more bronchodilators you use. So if you use one long-acting bronchodilator, you're good. But if you use two long-acting bronchodilators, you're probably better, depending on the severity of COPD. The more that balloon will deflate as you use more bronchodilators. What happens when you deflate a lung? The more you deflate it, the more air the patient can take in. So the more his inspiratory capacity. And what happens when the inspiratory capacity increases? The exercise capacity increases. So that patient can do more and walk more, feeling less breathless. And that is why I want to emphasize to you, there's one important message you need to take away, that a long-acting bronchodilator is so important and cardinal to the pharmacotherapy of COPD. But you need to tell the patient what it's doing, otherwise he's going to be confused as to why he's taking this drug, because it doesn't give him instant relief like patients with asthma get with short-acting bronchodilators. And over a period of a few days to weeks, he starts feeling much, much better, does more, walks more. Would you use a steroid inhaler for COPD? Well, if they get frequent exacerbations and they have severe disease, you may want to consider it. Also, if you get a lot of reversibility on the spirometry, more than 400 ml, it's almost like asthma. So you could have a smoker who also has asthma. Use an inhaled steroid. And new guidelines suggest that if the eosinophil count is more than 300 in the peripheral blood, also consider an inhaled steroid. Otherwise, the role of inhaled steroids is second line compared to what it is in asthma, where it is first line. Now about nutrition, a very important part of COPD management. And I can't emphasize how important it is. If you look at this slide, you will see that patients with COPD who are underweight, especially those with body mass indexes around 20, die sooner. And this is what we need to tell our underweight COPD patients. And ensure that they get adequate protein intake. Remember, they're losing muscle mass. Normal people lose muscle mass after the age of 30, 1% a year, and after 50, 2%. With COPD, that muscle mass loss is even faster. So you can imagine how much muscle mass they're losing and how much weaker they get. So even if their lungs are okay, their legs and their hands will not carry them to do what they want to do every day. So address weight loss and its causes, give them muscle training. And I'll just come to that. But experienced dietitians can help, especially when there are comorbidities like diabetes. And the second last part in education is about exercise. This is so important. This is half of COPD management, in my opinion. There's grade A evidence in the GOLD guidelines about exercise. I would rate it even more important than pharmacotherapy. Every COPD patient of yours should be put through an exercise program. If you have a cardiopulmonary physiotherapist, get them to be involved in a professional program, else at least get them to do basic exercises of hands and not just the lung. This is where we forget that it's not just the lungs that carry the patient through their day, it's their arms, their legs, their shoulder girdle, and their lungs. So when they do weight training, you can see the improvement and how much stronger they feel and better they feel. Remember that in an elderly patient, physical activity directly correlates with their quality of life. And the more physically active they are, the less depressed they are, the better their nutrition gets to ensure that physical activity improves. And these are two very important components. And you can see, even when these patients are put through a rehab program, even if they are so-called non-responders, they still live longer. And so you don't have to be a responder objectively in a pulmonary rehab program. You just got to do that exercise. Vaccinate these patients regularly. Remember, as you can see from this slide, even if a patient has a negative attitude to take a vaccine, if the doctor recommends it, the chances that the patient will take it are very high. However, if the patient comes to you saying that I want to get vaccinated, positive attitude, but the physician says no, is less than 10% chance the patient will get the vaccine. So physician recommendation, your communication to the patient that he needs a vaccine is very important. And I see this often where I've forgotten to actually write the vaccine on my prescription. And an assistant outside tells the patient, didn't he ask you about vaccination? And he comes back or he tells him, yes, I want to get vaccinated for pneumonia and flu. And finally, has the patient understood and is he comfortable with the treatment plan that you're giving him? And this is important because when the patient leaves your room, you've talked a lot about COPD now, and you may do this over 2 sessions, but has he understood what you really told him? And is he going to follow the advice? And look at his body language sometimes, because patients sometimes will listen to you and they won't understand if you've been talking for most of the time. Cardinal feature in communication is that the doctor should be talking for less than 50% of the time of the consult. Listen to the patient. It's extremely important. A study in Yale in the United States asked patients what they want from their physician. And they said they want a physician they can trust, a doctor who's competent, and a doctor who puts their priorities before anything else when he makes a treatment plan. And friends, can you imagine that only 2 of these, at least I learned in medical college. I mean, you learn how to be a competent doctor, but you're not often taught how to garner the patient's trust and how to put the patient's priorities before anything else when you make your treatment plan. So share your decision with the patient. Listen to the patient. Just listen. Sometimes let the patient just talk for 2 minutes at a stretch because he doesn't want to be interrupted. Just listen to him those first 2 minutes and you'll hear things that many doctors before you never even heard or chose to hear. And you'll hear things that the patient wants that you will be able to probably offer that patient and garner their trust. So this is extremely important in respiratory medicine in general, and particularly for patients with advanced lung disease. And so I cannot emphasize that a great prescription, you may know all the drugs for COPD, which you have learned through these modules in the past talks as well, but a great prescription is not enough. You need to spend time, educate the patient about inhaler technique, about drugs, how they work. All of these are important in COPD management, not just the prescription. So to conclude, the key messages from my talk is first understand from your patient what has he or she understood till now when he walks or she walks into your clinic. The next thing is what do they want? Why have they come to you? What's their chief complaint? And if they're smokers, we learned how to spend a little time on smoking cessation and how to tell them there is a way to help them. The third is hyperinflation. You must improve, practice, keep practicing. That's what I did through my years of practice. Just practice how to speak better, communicate better. And with every consult, trust me, you'll get better. What is hyperinflation and how the bronchodilator, the long-acting bronchodilator works? It will be of immense use to you in ensuring your patients take that drug, that most important drug, correctly and regularly. Next, spend time on nutrition, exercises, and vaccination. In patients with COPD, these can go a long way to prevent exacerbations and improve the quality of their lives. And finally, very importantly, understand what the patient wants from you. What are their priorities? How much they can understand before just writing out that prescription. Thank you very much, and I hope you enjoy treating your COPD patients from today.